Good evening and welcome to Doctors on Call. It's the cough and cold season, so tonight we're going to expand on that and take your questions about lung problems, ranging from pneumonia and influenza to asthma, COPD, and lung cancer. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host tonight. We're ready to take your questions locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome tonight's panelists. Dr. Vance Bachelder, a pulmonologist with St. Luke's Pulmonary Medicine Associates. Dr. Sonja Bjerk, a pulmonologist with Essentia Health-Duluth Clinic. And Dr. Emily Onello, a family medicine physician with the Lake Superior Community Health Center and faculty member at the University of Minnesota Medical School Duluth. Our UMD medical students answering phones tonight are Johan Pearson from Park Rapids, Mike Rose from Castleton, North Dakota, and Ryan Smith from Zimmerman, Minnesota. Well, now on to our first questions. Dr. Bachelder, maybe we should just get a definition here. First of all, what's the difference between asthma and COPD? That was mentioned in the intro.
It's interesting. They're both obstructive processes where when you're breathing in and out, there's not very efficient use of the air getting in and out. So that with asthma, you have a restriction of the airway, whereas with COPD, you have typically some loss of elasticity, although you can also have some airway destruction as well. Typically with asthma, you've got a lot of airway inflammation on the inside. The lumen, the mucous membranes are swollen. The musculature is sensitive, and there's also a lot of reversibility, meaning that when somebody takes an inhaler or dilates uses a bronchodilator where the muscles will dilate, a lot of the obstruction will resolve. Now, someone with COPD, it's almost always, not always, but almost always a smoking lung disease where there's destruction of the lung parenchyma, also some of the small airways, and you can get what are called emphysematous changes where you get holes in the lungs and you lose this elasticity where the lung is kind of more like a balloon. If you blow it up and you let a balloon out, it'll blow around the room, whereas if you have something like a plastic sack from the grocery store, you blow that up, that's not gonna work very well. And so COPD is a little bit more the plastic sack sort of a scenario.
That's interesting.
So it's mostly an efficiency of getting air in and out with that. So,
thank you.
Sure.
Well, Dr. Bjerk, it also mentioned in the promo, this is cough and cold season. Everybody's coughing that I've been around. Mm-hmm. So tell me about coughing, particularly coughing that lasts for a while. What are the causes of that?
Yeah, so chronic cough is a very common problem that affects many people, and we see a lot of patients for it. This time of year, the most common cause is that you had a cold. A post-infectious cough can last up to 6 months, which can be very frustrating, especially if you had the cold. And so that's really the most common form of cough this time of year.
Well, thank you. Mm-hmm. Dr. Onello also mentioned on there was lung cancer. And what are the symptoms of lung cancer? When should people be concerned regarding that?
Yes, I think that's a diagnosis that many of us are fearful about, and especially when we have something like a cough that's extending beyond the time we would expect for a cold or an upper respiratory infection. So I would put cough as a common symptom, but also some other symptoms that you might not necessarily connect with your lungs right away would be weight loss, unexplained, unintended weight loss, not feeling well, generally fatigued, possibly even coughing up abnormal secretions or what we call phlegm or blood in the phlegm, which can be lots of other things. I want your viewers to understand that this does not mean you have lung cancer if you have these things, but certainly weight loss, fevers, not feeling well, shortness of breath as well. Sure. Could be signs that something abnormal might be developing.
So any concern, they should see their physician and have tests done?
Right, I think so. That would be wise, right?
Great, thank you. We already have some questions. Dr. Bachelder, a caller from Cloquet would like to know about bronchiectasis. Is that serious, and how do you get that?
Yeah, that is interesting. There's a lot of what we call idiopathic kinds of bronchiectasis where we don't really understand the cause. But essentially what it is that you get thickening and dilation of the airways sort of deep down into the lung where it shouldn't be that dilated. Usually the lung tubing tapers like a tree trunk, and the branches and everything coming off. Whereas, you know, if you have bronchiectasis, the tapering happens much less acutely, and so it's dilated, and you get thickening of the wall of the membrane. Most of the time, it's secondary to infection, chronic infection. So people with cystic fibrosis or secretions that they cannot clear. Sometimes people with COPD who have a chronic bronchitis component where they always have a little bit of that smoker's mucus in there, and they're constantly getting these recurrent infections. That over time can lead to bronchiectasis. Mm-hmm. Bronchiectasis in and of itself probably isn't too much to worry about, except that it's just a marker for needing to have what's called good pulmonary toilet, trying to get the secretions out of there, making sure that you're coughing, deep breathing, getting that stuff out of there that can become infected. And so I think that's the main thing. And bronchiectasis also can predispose to more infections and more bronchitis down the road. But that's what you have to do, is just do your best to try and keep those secretions out of there. So
thank you. Dr. Bjerk, a caller from Mountain Iron would like to know, have you heard about stem cell treatment for COPD?
Yeah, I've actually been asked that a couple of times by some of my patients, and I typically refer them to a center that does the research. I do know that it's going on at certain centers. I myself have never had a patient that has done it or found a center that they could go to for that.
How does it work? Do they inhale it, or do they get it injected? Or?
I'm not entirely sure, actually. Yeah, there's different ways. Yep. Mm-hmm.
Interesting. Dr. Onello, a caller from Hermantown would like to know, does COPD cause lung cancer?
That's an interesting way to ask that question. Mm-hmm. I think, my pulmonology colleagues could weigh in on this. I think that as we heard earlier, given that smoking is so closely correlated with COPD, and smoking being a risk factor for lung cancer, in fact, I think the number one risk factor, they go together. And so I certainly think having COPD, particularly if you're a smoker, would put you at added risk for lung cancer. In terms of causing it, I would not say that it causes lung cancer, if you'd agree with that.
Thank you. Dr. Bachelder, a caller from Cloquet would like to know about histoplasmosis. How do someone get histoplasmosis, and how is it treated?
That is an interesting question. You can get histoplasmosis. It's a fungus, and typically there are these spores in the air. There's lots of fungal spores that we're always breathing all the time, and usually our immune system will just take care of it. It's not too much of an issue. However, there are some people who have what's called immunocompromised, where they're either on steroids or they've had part of their immune system is not working correctly, and sometimes maybe chemotherapy, something of that nature. And so if their immune system is not working all that well, then those spores, rather than being taken care of, can sometimes take root and start to grow. Sometimes a healthy person can get histo, but they usually have to have some type of specific exposure, and sometimes that can be, sometimes dramatic, like, if you're a spelunker and like to go into bat caves and you're exposed to, bat guano. I mean, that could be one way, and so there are specific ways that a person can get it if they're healthy, but most of the time it's going to be somebody who's immunocompromised. The treatment is usually these antifungal medications. There's a couple different kinds that could be used. Ketoconazole and itraconazole are ones that are used frequently. They are usually taken for long periods of time. We're talking maybe 9 months, 6 months, 9 months, something like that, depending on what it looks like on initial presentation. The other thing is that these medications, they're a little bit hard to take because they can chew on your liver a little bit, and so you got to kind of watch that. Yeah, but and sometimes can be hard to eradicate, but yeah.
Thank you. Dr. Bjerk, a caller from Chisholm would like to know about the water reservoir in a CPAP machine. Can that spread respiratory diseases?
Yes, it actually can if you're not cleaning it. It can't really spread it, but it can cause worsening of your breathing and worsening of the symptoms that you may have.
And kind of explain, a CPAP is for sleep apnea.
For sleep apnea,
and it's a device, and then there's a little water reservoir
Yeah,
attached
and
to
this
it.
time of year, you like to put water in the reservoir because it's so dry. So if you're waking up a lot at nighttime with a really dry mouth, you might need to increase the humidity in the CPAP machine. Yeah.
Great. Dr. Onello, let's see. I'm just looking at my cards here. How about interstitial lung disease? I know that's a big topic, but we have a caller from Duluth who'd like to know. I mean, we talk about emphysema and asthma and all that, but there are other types of scarring of the lung?
Yes, and that's very helpful that we have kind of a multi-specialty team here, because as a family physician, that's less common in my practice. Typical things that I would see would be asthma and COPD, upper respiratory infections, but certainly interstitial lung diseases would be the sort of diagnosis that may be a little more challenging to get to, and that may have certain findings on lung testing and imaging, such as a CT scan of the chest, and where often I will work with specialists to sort of figure out what's going on in the lungs.
That's a good referral topic there. When
Yes.
it comes to the, I know.
I think so.
I have also another caller here from, I believe, the Range. Would like to know about adenocarcinoma of the lung. Dr. Bachelder, is there anything new about that disease or the treatment?
Well, there's a lot of different types of trials that are going on out there. I have to admit that the specifics of each cancer and exactly what is it, exactly cutting edge is not something I deal with daily, but I know that tyrosine kinase inhibitors are kind of new on the scene. And so there's a lot of trials going on with those types of medications. I know the University of Minnesota is doing some trials with those types of medications. And adenocarcinoma is what's called a non-small cell lung cancer. And the reason they lump them into a small cell and non-small cell is that a small cell is typically very rapidly progressive and usually not a surgical disease, whereas non-small cell, depending on the staging, is typically both, it can be just resection, just a surgical disease, or surgery with chemotherapy, or sometimes even with radiation, depending on the staging. So that's one thing about adenocarcinoma, is that as far as the prognosis, it depends on what the stage is and what kind of treatment you are willing or can tolerate. I mean, a lot of people with lung cancer have really bad COPD, and so they don't necessarily tolerate radiation all that well or chemotherapy all that well. So a lot of these decisions have to be very individualized.
Thank you. Dr. Bjerk, a caller from Duluth has a sore throat, but also has been doing a lot of coughing of mucus, white mucus. Now, this gets into the topic of bronchitis. So what's bronchitis, and when is that something that antibiotics are needed for?
Yeah, so typically bronchitis is really, technically, it's inflammation of your bronchi, so inflammation of your airways. And you can get that from bacteria, you can get that from viruses, but when you become more concerned about bronchitis is when you're starting to be short of breath, when you're starting to cough up more mucus that's colors that you've never seen before. When it's white, typically I'm not as concerned, but if people start coughing up different colors, so yellow, green, even blood, that's when you should seek help.
Thank you. Dr. Onello, a caller from Chisholm, would like to know about asbestos in the lung. What are the effects of asbestos on the lung?
Yeah, that's a great question, because as most of our viewers know, asbestos was widely used, I'm going to guess till about the 1970s or so, but it was used in a lot of building materials, and there were a lot of occupational exposures from shipyards to construction. And within the lung, you can get a condition I believe is called asbestosis. And then there's also the possibility that the asbestos fibers, once inhaled, can also cause inflammation and damage to the lining of the lung, called the pleura. And in some cases, as many folks are aware, there's been interest and concern that there may even long-term exposure could increase your risk of a type of cancer of the lining of the lung called mesothelioma. So asbestos is now felt to be harmful in exposure, and we limit it. We protect ourselves when we're exposed to it with masks, or we avoid it and try and get rid of it when we can.
Thank you. Dr. Bachelder, a caller from Cloquet, would like to know about, again, the CPAP machine using for obstructive airway or for sleep apnea, and she would like to know, can you still get apneic episodes when you're on a CPAP machine, and how many are tolerable, or when is it felt to be good control?
Yeah, no, that's a very interesting question. The short answer is yes, you can still have apneic episodes. If the machine is set correctly, typically you're not going to have obstructive episodes. So the way CPAP works is, if you think about it, your throat is kind of like a floppy tube, and if you think about maybe, I don't know, an inner tube or a bike tire, if you have a flat tire, if you pump it up with air, it gets nice and round. The same thing is happening during sleep, is that you have these muscles in your throat that relax, and as they relax, the airway can become encroached upon and impinged, and so then the breathing becomes more difficult. And so the CPAP is just supposed to hold the airway open, again, like a bike pump or something similar. So that being said, there's another kind of breathing episode that, besides obstruction, is something called central sleep apnea, and that's where you're pausing your breathing because the brainstem or the respiratory centers are not telling you to breathe appropriately. And there is such a thing as what's called treatment emergent central sleep apnea, where when people first get on a CPAP machine, they can have these what are called baroreceptors, pressure receptors in the upper airway that are sensitive and can actually send the signal to the brainstem to not breathe. So you put this on and you get rid of the obstruction, but you have these intermittent pauses where you could breathe, but for whatever reason your brain is not breathing because of these signals. So the number that typically is used is five respiratory events per hour of sleep. So if you're having more than 5, that is thought to be in the abnormal range. That being said, though, if you're talking obstruction, not everybody with that range of sleep apnea necessarily needs to be treated. They should be treated if they have comorbidities such as things like diabetes or hypertension or pulmonary hypertension, other things predisposed to stroke, things of that nature. So if you have those kind of risk factors, then you should be treated even in the mild range. If you have a central sleep apnea, if it's from the machine, most of the time that will go away. Typically it will resolve over time, although there are some cases that do not. And under those circumstances, you have to have a specialized kind of machine, something called an auto SV.
Thank you.
Yeah. So.
Dr. Bjerk, a caller from Duluth would like to know more about, actually, a couple of callers, a hilar nodule and sarcoidosis. So maybe you could just tell us what's sarcoidosis? Yeah,
so sarcoidosis typically symptomatically can be just a cough. It can involve the lungs, it can involve many of the different organs of your body, and essentially we don't know exactly what sarcoidosis is. There's some theories that it's caused by a virus that we're all exposed to in our lifetime, but ultimately we don't really know what causes sarcoid. You can get sarcoid there's different stages in the lungs that you can get. The most common form that we tend to see is just lymph nodes in the chest. So hilar lymph nodes are lymph nodes that are, you have your trachea, and then they split into both right and left hilum. So that's your right bronchus and your left bronchus, and the lymph nodes sit right in that area. And typically, if we're looking for sarcoidosis, you find the lymph nodes and then you can biopsy them, and that's how you're diagnosed with sarcoidosis.
Thank you. Well, I should ask a follow-up question.
Yeah.
And what's the treatment? Do you have to treat everyone that has it?
You don't. You can treat people that are symptomatic, meaning that they're coughing and short of breath. But people that just have big lymph nodes in their chest, you don't necessarily have to treat them. And if you were to treat them, you use prednisone for that. And if they're resistant to prednisone, you start to use other medications.
Thank you. Dr. Onello, a caller from Chisholm, he smoked for 50 years, and he used to smoke 2 packs a day, but now he's down to 3 cigarettes a day. Is the lower amount okay now, or should he quit altogether?
Well, first, of course, let me commend him for his efforts.
Yeah, that's pretty remarkable.
That is very good, and I have had a few very special patients who were able to quit after 50 or 55 years of smoking, so it can be done. I want your viewers to know that. But also, I believe there is some medical literature suggesting that cutting down or cutting back is beneficial. So for those of you that are are not able to completely quit, it's still better to smoke less. But that certainly my advice, even though there's a 50-year history, would still be to work towards no cigarette smoking. The benefits of quitting completely are evident even on your cardiovascular system within 20 minutes to an hour after your last cigarette. So I would encourage him to press on and become a non-smoker and take the money he saves and do something fun.
Oh, yeah, absolutely. Good advice. Dr. Bachelder, a caller from Duluth would like to know, is COPD always fatal?
No, in fact, much of the time it is not. There is typically when someone is quitting smoking, the lung destruction that occurs is much slower or completely absent. Usually what you get are changes, there's physiologic changes with aging of the lung, but once you have stopped smoking, the COPD essentially stops progressing. It depends on when you stop and what types of deficits you have in the end. Some people have really profound deficits, and what tends to give them trouble is either ongoing smoking or recurrent infections. So if you were to get a really bad infection, you have very severe COPD, that potentially could be life-threatening. But most people with COPD won't necessarily die of that disease unless they continue to smoke or they get to a point where their breathing is so bad that any small infection could tip them over.
Thank you. Dr. Bjerk, a caller from Duluth would like to know, he's 50 years old, he had a positive Manto test, and he's been on INH therapy for a year. Now, how often does he need to have a chest X-ray done to follow up on that?
Yeah, that's a great question. Generally, I believe that if you're not really having any symptoms after you're treated and you're not in the healthcare field, you don't necessarily have to have a follow-up chest X-ray. People that have had a positive Manto and are working, in school systems or in the health systems, to monitor them, you will get a chest X-ray because you've been positive in the past. But typically, no, you don't have to have a surveillance chest X-ray because you've had a positive Manto.
Well, thank you. Well, we're getting near the end of our time here. Dr. Onello, caller from Cloquet would like to know smoking again. So how many years of smoking is bad? I mean, can you smoke for a few years and then you're okay? Now, he smoked for 29 years.
And I'm going to assume the caller's asking about tobacco smoking.
I would assume so.
Well, certainly, to wiggle out of the question a little, it also matters how much you smoke. So are you a 3-cigarette-a-day smoker or a 3-pack-a-day smoker? So we, in the healthcare field, we'll use a term called pack years, which you sort of correct for that, if you will. I don't know the scientific answer to that, but I certainly, the party line would be no smoking is good. But really, I think I start to get concerned about my patients when they've been smoking beyond 5 and 10 years. I'm not saying it's okay to smoke for 5 or 10 years, but rather that's when I start to worry about maybe some more permanent or long-term changes. And I certainly would be open to hearing what our pulmonologists think, but if it's a short-term thing, I would say 5 or 10 years. Beyond that, you're getting into
So if you're going to start smoking, you can do it at the age of 85? Would be a good time to start?
No.
Okay. No. All right. Well, let's see. And then just quickly, Dr. Bachelder, a caller from International Falls, father died of asbestos, mesothelioma. Are there any good treatments for mesothelioma these days, or is it still a very difficult thing?
It's still pretty difficult. There is a surgery that can be done at the University of Minnesota. They can do sort of a pleural stripping where they go in and take all of the lining off of the lung and out of the inside of the chest wall, trying to scrape it all out.
That sounds like a big deal.
Yeah, and the few patients I've had who've had that done did not necessarily have a great outcome. So at this point, there's still not a lot of great chemotherapeutic options, and obviously the surgical options are kind of radical. So it's still a pretty difficult disease at this point.
And chemotherapy really is not very
not too
effective
good,
either.
no.
Oh, I'm sorry to hear that. Well, I think we've come to the end of our time here. And really, I'd like to thank our panelists, Dr. Vance Bachelder, Dr. Sonja Bjerk, and Dr. Emily Onello. and our medical students, Jonah Pearson, Mike Rose, and Ryan Smith. Please join Dr. Ruth Wester next week for a program on cancer. And her panelists will be Dr. Lloyd Ketchum, Dr. Emily Onello again, repeat performance, and Dr. Mikhail Perloff. Thank you for watching, and good night.